You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 10th, 2026. We're back from holiday. This week, some listener feedback, FFR without a wire or catheter, more bad news for Ticagrelor, the Poly-HF trial, and oxygen targets after cardiac arrest. Let's first do some listener feedback. Virginia electrophysiologist Ian Willett sent me an important feedback on my coverage of the ICE intracardiac echo versus TEE trial for AF ablation. Now, this was a ways ago. JAMA Cardiology published a study in October 2025, first author Hugh. This was 1,800 patients having AF ablation were randomized in multiple centers in China to two strategies to rule out left atrial thrombus, either a TEE before the procedure or ICE during the procedure. And the primary endpoint of detection of left atrial clot was extremely low and not different. However, there was a substantial difference in major bleeding related to the transeptal puncture. 2 bleeds with ICE, 11 with TEE, hazard ratio 0.18, and a p-value of 0.03. Dr. Willett pointed out that something I had not realized, that while ICE allowed for real-time imaging of the transeptal puncture, the TEE in this trial was done before the procedure and, quote, transeptal puncture was performed under fluoroscopy. And so his point is that in this trial, it was not TEE versus ICE for the safety of the procedure, but an imaging versus non-imaging approach to transeptal puncture. Dr. Willett tells me in his email that he has done 99% of his transeptals under TEE guidance for 15 years and rarely opens an ICE catheter anymore. He does not want the This Week in Cardiology listeners to think that ICE is safer than TEE because in this trial it looks to be ICE versus fluoroscopy. Now, I think this is an important point because I wouldn't want listeners to take from this trial that ICE was superior to TEE for safety of transeptal punctures either. Many centers worldwide do TEE during the procedure and use it for both exclusion of left atrial clot and real-time imaging of the transeptal puncture. The Hugh et al. Study does not look to have compared the two modalities for the safety of transeptal puncture. The thing is that if you believe all patients should have a TEE imaging before ablation to exclude clots, I don't believe that, but if you did believe that, you could likely just use the transesophageal echo to guide the transeptal. I appreciate this feedback that Dr. Willett gave me because not only does it better clarify translation of this trial, but his comments also highlight how important it is to study the trial procedures part of manuscripts. A manuscript, you look, patients, baseline characteristics, trial procedure, endpoints, and results, they're all equally important to understanding clinical trials and to translate these trials. So thank you to Dr. Willett for the great feedback. All right, first topic today is a long one, and it's interesting. New England Journal put 2 angiography-derived FFR trials in the July 1st edition. One trial was called Fast 3 and the other trial was called All Rise. Now, they were presented as ACC late breakers. They were published online then, and I did not cover them at the time, mainly because the trials kind of confused me. I've never heard about angiography-derived FFR. I had only known that FFR is defined as the ratio of distal coronary pressure to aortic pressure during maximal hyperemia, and it quantifies how much a stenosis limits achievable blood flow. Now, whether physiology in the lab is measured with hyperemic agents or an instantaneous wave-free ratio, both of these techniques require putting a catheter into the coronary artery, which is not nothing because it takes time and it creates extra risk. Now, I have slides that question the true value of any FFR or old school FFR because FFR was established on the flawed FAME-2 trial, showing that FFR-guided PCI reduced outcomes relative to medical therapy. But this was an unblinded trial. It was driven only by urgent revascularization in the unfixed or medical therapy arm. There was no difference in hard outcomes, and FAME-2 was a classic example of subtraction anxiety, meaning patients got randomized to not being fixed, and the first time they had a twitch in their chest, boom, they had urgent revascularization. Nevertheless, just like left atrial appendage occlusion, cardiologists have embraced the idea of physiologic assessment. It carries a class 1 recommendation, and to question it is almost heresy. But you should go back and look at FAME-2. But let's not get into that now. Let's just assume FFR isn't useless. These two trials set out to assess whether a computer-based software or imaging technique could ascertain coronary physiology from the angiographic images. Here's a copy and paste from the All-Rise trial manuscript. They write that this computer-based software analyzes the coronary angio images, and they create a three-dimensional reconstruction of the tree, and they apply a resistance model to estimate pressure gradients on the basis of vessel contours. Honestly, this is what it says. The system, FFR Angio, which I'm sure is brand named and a company system, quantifies angiography-derived FFR, and it correlates well with pressure wire-derived FFR, but does not require a pressure wire or hyperemic agent. So there you go. You can just get the image, and you can do FFR without the downsides. So in All-Rise, nearly 2,000 patients with at least one intermediate coronary stenosis were randomized to a physiologic assessment with measurements derived from the FFR angiogram or with standard pressure wire-based measurements. The primary endpoint was MACE, death, MI, or unplanned revascularization at 1 year. The assessment was with non-inferiority. They assessed an absolute risk margin of 3.5 percentage points. The expected event rate was 7.5%. So if you do 7.5% and 3.5, the relative risk margin is 1.46, which is pretty generous. The main results of the trial: the mean age of patients 68 years, 25% women. A huge note in Table 2. The huge note. This is really important. The number of studied lesions treated with PCI, 44.3% in the FFR angiogram group, 35.4% with pressure wire. So when we were counting coronary revascularization at 1 year, note the 9% higher rate of PCI initially in the FFR angiogram group. So at 1 year, this is what sits in the New England Journal of Medicine. A primary endpoint occurred in 64 patients. That's 6.9% in the FFR angiogram group, and 65 patients in the pressure wire group. That's 7.1%. The absolute risk difference is only 0.2 percentage points, and the upper bound of that one-sided confidence interval was 2.1 percentage points, and 2.1 was less than the agreed-upon margin of 3.5%. So this met statistical significance for non-inferiority. Bleeding, AKI, or procedure-related adverse events did not differ into two groups, and the authors concluded that this was non-inferior to pressure wire-guided strategy using this composite endpoint. All right, before I go into comments, let me just discuss the FAST-3 trial, which is also published in New England Journal of Medicine, and the idea is similar, only the company is different. Here's an excerpt about the different imaging. This was vessel fractional flow reserve, so VFFR, from a company called Pi Medical Imaging. And this derives an FFR value from the angiographic images and 3D quantitative coronary angiography by using, quote, physical laws that apply to coronary flow behavior, including, quote, viscous resistance and effects of separation loss, whatever all that means. Patients in the two trials were similar. They could have chronic or acute coronary syndromes. In FAST-3, randomized 2,200 patients at 37 European sites. It was open label, the VFFR versus pressure wire FFR. And again, at baseline, the number of lesions positive Angio versus wire, 41 versus 31%, and the all-important, quote, any revascularization performed at baseline, 59% versus 52% in the VFFR versus regular FFR groups. And so the endpoint, same flavor, death, MI, or any revascularization at 1 year, both groups 7.5%, upper bound of the risk difference 2.2%, so non-inferior margin easily met. The authors also concluded non-inferiority of this version of angiographic determined FFR. Now, the editorial in the New England Journal explains that A, ischemia burden matters, invasive assessment is underused, and these two trials show non-inferiority. That's it. There's a nice image, there's a bullet list of key concepts, and this editorial New England Journal of Medicine looks like it's been large language modeled so that everybody can easily digest it, which I hope is not becoming a trend. Anyways, my comments. As pointed out by my friend and one of the smartest cardiologists I know, Venk Murthy from Michigan, the fatal flaw in these two industry-sponsored trials is that the choice of endpoint does not penalize the index PCI decision itself. Only death, MI, or subsequent revascularization count for the trials. Now, if you take them together, the rates of death and MI were low in these trials, and they weren't statistically different. So it didn't look like there was a difference in major endpoints. The rates of subsequent revascularization were also similar, which led both trials to get under that 3% non-inferiority margin. But come on. If revascularization is supposed to be an endpoint to avoid, right? You want it lower, then you have to count all the PCIs. The new FFR techniques lead to about 9% more PCI initially, and if these were added to the total, then non-inferiority would not have been met, not even close. Oh, I'm just a simple EP doctor, but if you treat more lesions at baseline, then would there not be less to do later? Therefore, this new tool can't really tell if there's a better detection of lesions or simply a lower threshold and more overtreatment. The fact that CV death and all-cause death are not different in either trial makes me think it's probably just all overuse of PCI. What is more, how do you pick up any harm signal from the extra PCI with just 1 year follow-up? Right? Bad things like stent thrombosis, restenosis, and bleeding from the necessary antiplatelet drugs, that takes time. Another problem, these two trials stand in opposition to the FAVOR 3 trial of QFR, quantitative flow ratio, which is an angiography-based computational method for estimating FFR. This was published in The Lancet, and it found that the non-wire-based method not only did not reach non-inferiority, but was clearly inferior to standard FFR. Now, perhaps the non-wire method matters, and the QFR left too many significant lesions untreated, but perhaps there is just a lot of noise in these results. I mean, what would a meta-analysis of all the non-wire methods look like? But here's the bottom line. I am strongly concerned that the entire basis of physiologic coronary assessment is flawed. It was only urgent revascularization in the unblinded FAME-2 trial that drove the benefit. There was no difference in death or MI. Now we simply have two new, likely pricey methods to assess a likely flawed assessment. I'm happy for you to tell me why I'm wrong and why I should not be cynical. Cynical because doctors may embrace a fancy new non-wire technique, one that leads to 10% more PCI being done. Money will be spent on the new FFR method and more PCIs that'll be done, and there's no evidence that it reduces MI or death. I suspect that there'll be pictures of shiny, happy cath lab reps with banners and cakes to celebrate the 500th use of non-invasive FFR techniques. All right, next topic is more bad news for Ticagrelor. As many of you know, I remain perplexed by the popularity of Ticagrelor over clopidogrel and prasugrel for post-stent antiplatelet use. Well, JAMA Cardiology has published a meta-analysis of 15 RCTs that compared different combinations of the three drug options. Nearly 49,000 patients were included in these 15 trials, and the primary efficacy endpoint of the meta-analysis was MACE, and they also looked at safety endpoints like major bleeding. The primary analysis compared Prasugrel and Ticagrelor to Clopidogrel, and these trials included ones that you'll recognize, right? Triton, TIMI, Disperse 2, Plato, PROSFIT, PROG 18, Elderly ACS, Alpheus, Tuxedo 2. You'll know all these trials. Okay, so figure 1 is the forest plots looking at the combinations for MACE. And Prasugrel versus Clopidogrel hazard or odds ratio 0.80 favoring Prasugrel. Ticagrelor versus Clopidogrel, no difference. Ticagrelor versus Prasugrel, hazard or odds ratio 1.21 favoring Prasugrel. All-cause mortality right around the null line, myocardial infarction. Again, Prasugrel looks superior to Clopidogrel, about the same as Ticagrelor, Clopidogrel, about the same. Ticagrelor versus Prasugrel, better with Prasugrel. Stent thrombosis, much better with Prasugrel versus Clopidogrel. Ticagrelor versus Clopidogrel looked better, but Ticagrelor versus Prasugrel, the odds ratio 1.52 worse with Ticagrelor, better with Prasugrel. For safety, major bleeding, basically no difference except for Ticagrelor looked worse than Clopidogrel by a little bit. Intracranial hemorrhage, again, Ticagrelor looked worse than Clopidogrel. And drug discontinuation, strongly worse with Ticagrelor, odds ratio 2.0 for drug discontinuation. The authors provide a bar graph of the probability of the antiplatelets being the best comparing the three strategies. And for MACE, clearly, Prasugrel looks better. For major bleeding, Clopidogrel looks to be the best. And in all cases, Ticagrelor looks to be the least effective. And so here's the author's first paragraph in the discussion. They write that there was a lower risk of MACE with Prasugrel compared to Clopidogrel. It was driven by lower MI and stent thrombosis. Further, there was a lower risk of MACE with Prasugrel compared to Ticagrelor, driven by lower MI and stent thrombosis. Thirdly, there was a higher risk of major bleeding with Ticagrelor compared to Clopidogrel, driven by higher rates of ICH. Prasugrel ranked first, followed by Ticagrelor and Clopidogrel for MACE, MI, and stent thrombosis. For major bleeding, ICH, and drug discontinuation due to adverse events, Clopidogrel ranked first, followed by Prasugrel and Ticagrelor. And their assessment is that Prasugrel provided the optimal balance between efficacy and safety. So my comments, there are surely issues with different populations in these trials. There was different follow-up times. There are also trials that are mixed in geography and ethnicity. But as an outside observer, I see that the once-daily medicine Prasugrel looks superior to Ticagrelor, a twice-daily medicine with this pesky side effect of dyspnea. I mean, I think it's probably always best to put more weight on large, well-done, conducted individual trials like, say, ISAR React 5 versus meta-analysis, but this meta-analysis adds more weight to my contention that Prasugrel is superior to Ticagrelor. So when an operator feels they need more than Clopidogrel, going to Prasugrel makes the most sense. Again, I'm open to changing my mind on this. If you can look at this meta-analysis and see why Ticagrelor is so popular, please do let me know, especially given the monster problems that I have covered in the previous Plato trial of Ticagrelor versus Clopidogrel. All right, next topic, the Polypill in heart failure. Nature Medicine published a Poly-HF trial from 2 large Texas centers. The more than 5,000 charts in the electronic health record were screened to invite 474 patients with HFrEF who were already on meds to participate in a pragmatic RCT comparing a Polypill, which had metoprolol succinate in multiple different strengths, spironolactone 12.5, EMPA 10, versus just enhanced usual care. Ultimately, from the 5,000 patients, 212 patients were randomized, so about 100 in each group. Both groups received sacubitril valsartan, which was not part of the Polypill. And this is a good design point because clearly the absolute most important thing to do with patients with HFrEF is afterload reduction with some sort of RAS blocker because the single problem in HFrEF is elevated systemic vascular resistance due to LV dysfunction. The primary endpoint of the Poly-HF trial was LV ejection fraction at 6 months assessed by MRI. They had a slew of secondary endpoints, and they even calculated a win ratio based on many composite endpoints. It was a positive trial. Left ventricular ejection fraction was 40.4%, Polypill 37.1% in the control arm. That 3.3% difference in ejection fraction had 95% confidence intervals above 1, and the p-value was 0.039, so just snaked under the 0.5% threshold. But heart failure hospitalizations were massively reduced. 37 versus 86 per 100 patient years, rate ratio 0.40, so a 60% reduction in heart failure hospitalizations with the Polypill. KCCQ was better, medication adherence was better, and adverse events were very low and not different in the two treatment arms. Notably, the BNP was not different. The authors concluded, what else could they conclude? That the Polypill increased adherence and led to significant improvement in cardiac function. So my comments, there are many things to say about this trial. First is that despite the aggressive urging from heart failure key opinion leaders, starting heart failure medicines is very hard in real life. Patients look at you askance when you tell a newly diagnosed person that they have to take these four pills for life, plus all the other pills, but these 4 pills for life. And even when they accept it, it's super hard to maintain 4 prescriptions and take 4 pills per day. You have to go to the pharmacy, you have to make sure the insurance has covered it, you have to pick it up, get in your car, come back. Maybe you don't have a car, maybe you don't have a ride, maybe you're an older person. It's not easy taking 4 pills per day. So the idea of simplifying the regimen is a good one. I've become more open to the idea of a polypill based solely on decreasing the work of being a patient. But there are many caveats to this trial that deserve mention. First is that these were highly selected patients. They looked at 5,000 charts to enroll 200 patients. The authors call it a pragmatic trial, but in reality, it's a highly selective trial. Most important though, this is the key. These patients were already on drug therapy. They had showed previously that they could tolerate the medicines. Their baseline age was 53 years. These were young people, and their systolic blood pressure on medicines was 120. So I write this in caps. This is totally different than the vast majority of patients I see with heart failure. The patients I see with HFrEF are either older, or they have more comorbidity, or their heart failure is new in onset, and you have no idea whether their blood pressure will tolerate all these medicines. The second caveat is that the primary endpoint here is almost laughable. Ejection fraction is one of the things that always makes me smile. I just laugh when I see ejection fraction. Here was a statistically significant 3% better EF in the Polypill arm. Now, I'm not sure about MRI, but a 3% difference on echo EF could easily be related to whether the reader read the image before or after lunch. I make fun of this, but not well known is the lack of precision in left ventricular ejection fraction estimates. I trained with Harvey Feigenbaum at Indiana, and we had 4 ejection fractions at IU: normal, mildly reduced, moderately reduced, and severely reduced. Dr. Feigenbaum pushed back on the false precision of putting these numbers on ejection fractions. Now, I realize that trials and billing criteria require a number, but when I read that an ejection fraction is 35.3%, I laugh, because if it were 35%, that patient would be eligible for an ICD. But if we implant an ICD and ejection fraction is 35.3%, we risk getting charged with fraud. But of course there's no difference. So a 3% increase may meet statistical criteria, but is clinically meaningless. I would also throw out the improvement in KCCQ given the open label nature of this study. Finally, the reduction in heart failure hospitalizations is massive. It's a 60% reduction, hazard ratio 0.4. Now, how do you get this much effect in heart failure hospitalizations with no difference in mortality and no difference in EF and no difference in BNP? Again, I think this likely represents a performance bias, wherein patients on the Polypill are less likely to be admitted to the hospital. This isn't nefarious. This is just humans acting like humans. People are probably want the Polypill to work. A patient comes in with heart failure. You're like, they're on the Polypill. We could probably just get away with, going to furosemide 80 as an outpatient. What I would like to see in heart failure is a proper trial testing the expert opinion-led idea that simultaneous and rapid titration of multiple meds is better than a stepwise initiation and titration of single meds to a good dose. Now, we have the STRONG-HF trial. It attempted to answer this question, but due to serious design issues, it does not answer the question. The Polypill may help a tiny number of patients with heart failure who have already been on good doses of medicines for a good period of time, but this trial does not increase my enthusiasm one bit. Also, the concept that the Polypill may be better served in treating primary prevention conditions like hypertension rather than heart failure. Okay, final topic is a brief one. New England Journal of Medicine has published the logical trial, and this was conservative versus liberal oxygen supplementation in survivors of cardiac arrest. Now, conservative oxygen is all the rage these days, and it's counter to how we were trained back in the day that oxygen is important, so you give more of it. In the conservative arm of the trial, the lower saturation limit was 90%, upper limit was 95%, and FiO2 was decreased to room air even if the saturation was above the lower limit. So in this group, the authors sought to minimize exposure to a saturation of 95% or higher by mandating the use of an alarm that was set to sound when the oxygen sat was 95% or more, or whenever supplemental oxygen was administered in the ICU. In the liberal oxygen group, there were no specific measures limiting the upper saturation, but the minimum FiO2 permitted during mechanical ventilation was 0.3. The primary outcome was favorable neurologic function measured by Glasgow outcome scale, and it was done at 180 days after randomization. Now, they randomized more than 1,800 patients in 53 ICUs in Australia, New Zealand, and Ireland. These were about 60-year-olds with mostly out-of-hospital cardiac arrest. The first finding was that the conservative arm spent far less time with SATs greater than 97%, but they also had a higher number of at least one oxygen content of less than 60. And the median percentage of hours per patient on room air was 38 hours versus 0 in the liberal oxygen group. I mention this data because if high oxygen is felt to be bad for neurologic recovery, it's true in this case that the conservative arm received a lot less oxygen and had less measures of high oxygen content. The main results were totally null. 38% versus 39% had favorable neural recovery. The relative risk ratio, 0.97, with very tight confidence intervals of 0.87 to 1.09. And the same null effect was on overall mortality and quality of life. Now, you may wonder why I mentioned this negative trial. Well, I did not know this, but two previous smaller trials, one from Australia and the other a subgroup analysis of the pilot trial from Vanderbilt, had suggested better outcomes from lesser oxygen targets. Now, a trial from Denmark from 2022 did not find any difference in the two oxygen targets. So you have all this uncertainty, two positive trials, one negative trial. Logical was a much larger trial, had more power, and it found what you would expect, no difference. Oh, I really enjoy following our ICU colleagues because they seem to love trials, which is good. The problem, though, with ICU trials is that there are many things on the causal path from, say, out-of-hospital cardiac arrest to a good outcome. It's the same problem with sepsis and ARDS and shock of any kind. There's a lot of things on the causal pathway from that disease to a good outcome. For instance, there is luck, there is avoidance of ICU complications, there's optimizing blood pressure, kidney function, all of these things. And oxygen targets are but one thing. So randomization balances all the factors, but in my mind, it's hard for me to see how something so small, an oxygen target, can affect something so big, so far downstream. I think the other message is to be wary of smaller studies. In the Vanderbilt sub-study in chest, the favorable neuro outcome was 10% better in absolute terms. That's a massive difference. It's likely to be noise. Why is it likely to be noise? Well, despite the 10% better rate of favorable outcome, the p-value was 0.03. So small studies with fragile statistical numbers should make you very cautious. Logical was a big study with tight confidence intervals around the null, and it refuted the two smaller studies and confirmed the Danish study showing no change or no difference. All this said, I am glad ICU docs randomize so much. We cardiologists should learn from them. We need to randomize more. For instance, how about we randomize people with atrial fibrillation who truly cannot take oral anticoagulation to appendage closure versus no anticoagulation. The patients who get randomized to no anticoagulation get to go to lunch with their loved ones, and the patients who get randomized to appendage closure get to have a procedure with the 3 to 5% complication rate. So right off the bat, you have the control arm, which is already advantaged. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. If you like this podcast, please take the time to give us a rating, write us a review. If you don't agree with anything I said, send me a note. We can do listener feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.